Good afternoon, everyone. My name is Wierda from the MD Anderson Cancer Center, and you're joining us today for the CLL session entitled Exceeding Expectations in CLL, Workshops on Targeted Standards, Sequential Options, and Emerging Therapeutics for Treatment-Based Care. I'm joined by my esteemed colleagues, Allan Lamanna from New York Presbyterian Columbia University in New York City, and John Allen from the Weill Cornell Medicine, also in New York City. This program, as you know, probably is sponsored by PeerView and Medical Learning Institute, and their this work is supported by several sponsors that you can see on this slide. I won't read them for you. There is an interactive component to this. If you scan the QR code, there will be questions to answer, and you will also be able to submit questions. We don't have microphones around the room, so we're relying on that platform for submission of questions, so we'll be happy to review your questions. There is CME credit for this, and you will be able to view the content and download the content for this program. And you can see the website there. So we'll start off with a question. In your practice, which of the following represents a challenge related to the use of targeted therapy in treatment-naive or relapsed refractory CLL? And please select all that apply. Choosing between time-limited and continuous therapy, choosing between covalent BTKI options, knowing when to use non-covalent Bruton's tyrosine kinase inhibitors, sequencing between covalent BTKI, BCL2 inhibitor regimens, and non-covalent BTKI, and knowing when to use BTKI plus BCL2 inhibitor combinations. So please scan in, submit your response, and you can select more than one. And with the content of this program, I guess we're not going to see, I can't see. So sequencing between small molecule inhibitors seems to be the most commonly selected, followed by choosing between time-limited and continuous therapy. As you all know, we have made great progress in treatment for patients with chronic lymphocytic leukemia over the recent decade, with numerous agents being approved for patients, both in the frontline setting and in the relapsed setting. This slide summarizes those agents that are currently approved for treatment, and I think much of our thought and planning currently and discussion with patients is around optimizing treatment for our patients. We have a number of standards of care available, many of which are correct treatments or appropriate treatments, I should say. There are few instances where a treatment would be inappropriate, one of which I would give you as an example would be using chemoimmunotherapy for a patient with 17p deletion or mutated TP53. But by and large, there are treatment options available for patient, and selecting the right treatment for our patients it can be a challenge, and there's data that we're going to be reviewing today that will help inform that. This slide summarizes real-world data and sort of illustrates the fact that, yes, there are options, and you can see over the last 4 years, the proportion of patients who are treated in the frontline setting with the various treatment options, whether it's a BTK inhibitor, BCL2 inhibitor, CD20 antibody, or chemoimmunotherapy. Interestingly, there still is a fair amount of chemoimmunotherapy being used, about a 20% rate as first-line therapy, and you can see the highest proportion of patients are treated in the frontline setting with a BTKI inhibitor currently. But we're going to be reviewing data, and I think many of the new randomized trials will be with time-limited therapy, and so a lot of the new data that will come out over the next 3 to 5 years will be time-limited therapy and not necessarily focused on maintenance strategies with the BTK inhibitor. The two main targets that we have in chronic lymphocytic leukemia that are targeted with small molecule inhibitors are Bruton's tyrosine kinase and BCL2. Now, there are patients who have seen those agents and do develop resistance. And so one area of unmet need is in the refractory setting. That's sort of a moving target in terms of how we define refractory. And this data illustrates the poor prognosis and outcome associated with patients having refractoriness to both BTK inhibitor and BCL2 inhibitor. Short progression-free survival on the left, short overall survival. It's better for patients who are exposed and don't stop treatment because they're refractory. And in this case, refractoriness is defined as progression of disease while on treatment. And as I mentioned, this is sort of a moving target. We now have agents that are approved in this setting, for example, Lysocell, which we'll hear about. And so that definition for the unmet need and where we can make advances in our treatments for patients with CLL does change with time. These are the goals for today: improve your knowledge in support of first-line and sequential use of modern therapeutics, equip you with skills you need to develop treatment plans with continuous or time-limited strategies, and provide you with guidance on managing dosing, safety, and treatment planning in the modern era of targeted therapy. And with that, I'm going to transition over. Our first speaker today will be Dr. John Allan, again from Weill Cornell Medicine, who is going to talk about continuous therapy and sequencing of therapy.
Thank you, Dr. Wierda, and it's a pleasure to be here. Nice to see everybody, and thank you for coming to this session to get some education about where we stand in the field with some of these new drugs and targeted agents and combinations that we'll be speaking about over the next hour. So we'll start with this case. Here's a patient with CLL, unmutated IGHV, no other additional high-risk features, diagnosed about 4 years prior, observed, now is 72 years of age, and has indications for therapy and has some bulk, disease bulk, which also kind of is a moving target, typically greater than 5 centimeters, absolutely greater than 10 centimeters, but has a decent burden of disease, and a deletion 11q is present with an unmutated IGHV. Otherwise, good organ function and needing treatment. So, Dr. Lamanna, just, when you see somebody like this, what are your thoughts just quickly and how you think about that patient and deciding amongst drugs and approaches?
Well, he's median age of CLL, and you said he didn't really have significant comorbidities. So this discussion becomes longer and longer as we have with our patients, particularly somebody like him. He does have some bulky disease, and he's deletion 11q, and he's unmutated. He could go for either a time-limited approach or continuous therapy. We talk about the risks, the side effects, and the pros and cons of each approaches. Because he's bulky, a BTK inhibitor is very nice in bulky disease and very easy to do. But you could do either or. He's a little, if he was older, I'd be leaning more because of his bulk and his deletion 11q, and he's unmutated to a BTK inhibitor as chronic continuous, but it's not to say that he couldn't do time limited either.
Yeah, absolutely. So, we didn't see what his white blood cell count was now, but this is somebody who's probably you're watching progression over time, and, you have many interactions with the patient to help start to make these decisions before you are just absolutely needing to get the patient out of hot water. And so it's a conversation that is ongoing. We still lack head-to-head data of different approaches to know for certain is there a type of patient that we should treat in a certain type of way. So it's really physician comfort, patient preferences, and kind of where some of the data will lead you towards certain approaches. So the patient is treated, and now 7 years later is progressing, and basically this is a refractory patient who's progressing on drug, and typically in my practice, and I think in many people's practices, we will reassess, and that's kind of a standard approach to reassess your risk factors. Were new things acquired? We're looking for fish. We're looking for NGS many times. You don't always have to retest IGHV, and typically we don't. That's usually the same throughout the lifetime of the patient. But nonetheless, this patient was progressing, and you send off some blood and identify a BTK mutation that is now present. Fortunately, no other mutations were identified, and the patient's controlled, not transforming, but clearly the white count is rising, and now you've identified kind of this higher risk scenario, but have a lot of good options behind you. And again, the question is, how do you choose? We will show you that data, and we'll help guide you through, typical approaches. Most commonly, you might be reaching for a BCL2 based treatment, but we also have data that supports other approaches like non-covalence here as well. But we'll show you some of that data and help you choose an approach for this patient. All right, so this patient went on and got venetoclax and rituximab based on that Murano data, which is a 2-year treatment. The patient stopped therapy, but unfortunately 10 months later starts to progress. Again, this is something that over the course of now, a decade or so, we are reassessing disease each time you treat. You want to look at what's evolving. But this is where our newer therapeutics come into play with non-covalent, specifically pirtobrutinib, as well as CAR-T after these double exposed patients, and we'll show you what that data looks like. So in this first scenario, the treatment-naive patient, time-limited venetoclax regimen or continuous therapies are adequate here. The presence of 11q, unmutated IGHV, the age and that bulk might lean you towards continuous therapy. There is some data that 11q patients respond very, very well to BTK inhibition. And so typically we might be favoring that in how this patient was treated. If those higher risk features, complex karyotype, del17p, that might lead us more towards a continuous therapy BTK. We'll see some of that data comparatively to fixed duration approaches, which we might expect maybe a little shorter remission. For this second scenario, now a relapsed refractory patient progressing on it, non-chemotherapy exposed, time-limited ven approaches are great. Typically, by the book is following Murano with 2 years of treatment and rituximab. I think, many people can use obinutuzumab. It's not something that you can't do. And whether or not you do 1 or 2 years, I think people still have discussions about, and we might even bring that up. Pirtobrutinib potentially has a role here. There is some data to support that. There is some guideline data there. It's off the indication technically, but nonetheless, you can think about it here as well. And then obviously CAR-T is typically after exposure to both of these agents, but nonetheless is something we have to start to be thinking about for this patient. So gone are the days of chemoimmunotherapy approaches in terms of frontline therapy, and gone are the days of really assessing your risk status. It is small molecule inhibitors, regardless of what your risk features are. While we might see some data that shows del17p patients might shorter remissions with a ven-based fixed duration or a time-limited approach, they still do very well. They can get MRD negative. They're off of drug. There's a lot of still pros, and we've not shown survival detriments necessarily, overall survival detriments based on these types of approaches. So nonetheless, it's the same regardless of age and risk features of your disease state, and these are typically BTK inhibitors and or time-limited therapy with ven-oben. Ibrutinib is also there as well, but due to long-term safety concerns, that has kind of been now an other recommended approach, but nonetheless is a very active agent and is a good therapy and has changed the world, obviously, to how we treat now. So here are the longer follow-up of big studies, phase 3 registrational studies that got these drugs approved. Ibrutinib has been around. We actually have 10-year data. The final analysis from Resonate-2 was reported over the summer at EHA with a median PFS. The benchmark has now been set for expectations in frontline BTK inhibitors in patients in frontline therapy with about 9 years median PFS. The overall survival at that 10-year mark was 70%. This is after treatment, mind you. Many of these patients have been observed before for many years. And so a great outcome for our patients. ibrutinib set that benchmark, but all of the others, the selective drugs are meeting it and potentially, possibly even exceeding it as you look historically where they are lining up at these various time points. Elevate-TN is 6-year data, and Sequoia data is now pushing close to 4 years. As you can see, the PFSs reported there, all similar. So the next big question is like, how do we optimize it for our highest risk patients? And in reality, I think our definition of high risk has evolved in the setting of targeted agents, and I think many of us would agree that it really is restricted to complex karyotype del17p p53 mutated patients. And historically speaking, PFS after FCR for these patients was about a year, and overall survival was about 3 years. Here we're seeing pooled data from 89 treated patients from multiple phase 3 clinical trials prospectively followed. We see is that this risk feature seemingly has been overcome, maybe not totally in full, but definitely dramatic improvement over historical controls with a 4-year PFS of 79% and close to 88% overall survival at this time point. This is not restricted to ibrutinib. This is the acalabrutinib similar pooled data analysis in del17p complex karyotype type patients. And again, lining up at this 4-year time point, 78% PFS, overall survival also very similar, and also not to be restricted to just acala and ibrutinib. Here is the zanubrutinib data from cohort 2 in the Sequoia, which is looking at 110 patients with del17p, now with close to 4 years of follow-up, 3.5 years of follow-up, again, tracking historically well. And what we have learned also at last year's ASH is that the NIH has shown 35 of patients with del17p treated with frontline ibrutinib. They were also pooled in the first curve that I showed you, but 34 patients have an overall survival, again, at 10 years of 70% and a median PFS right around 7 years. So looking very, very well for these patients who historically needed new treatment options. And so that has, I think, in many people's minds has become a standard for these high-risk patients, though we'll hear arguments potentially for other approaches. There's been a movement over the years to more selective BTK inhibitors. There was a lot of expectation, hype, phase 2 data showing low rates of BTK inhibitor class effects with selective drugs, and it wasn't until a few years prior when we actually had head-to-head data against ibrutinib with drugs like acalabrutinib and drugs like zanubrutinib that we actually kind of proved that more selective agents had less kind of off-target effects that then translated into mainly less cardiovascular events, which is the big risk that we're trying to avoid with BTK inhibitors and trying to mitigate at any cost possible. It is modest. There are BTK inhibitor class effects, but nonetheless, if you treat 100 patients and you prevent 5 AFibs from coming out, that is a win if you know that you're not doing any detriment to some long-term efficacy, which is all of these studies have proved. So there was a non-inferiority of acalabrutinib in these high-risk patients in relapse refractory settings, but clearly less AFib, less hypertension, less bleeding. Same story kind of being told with zanubrutinib in the Alpine study. Again, a relapse refractory study going head-to-head against ibrutinib. And here we see the same data being shown here with less AFib, similar rates of hypertension, maybe a unique property to acalabrutinib, similar rates of bleeding. This study did show a PFS benefit technically, and we can talk about the study designs and things like that, but it is a phase 3 clinical trial, and it did actually show superior PFS in a very different patient population and at a slightly different time period of the study ongoing. But nonetheless, an active agent, high response rates, and in fact, this PFS benefit with this lower rate of cardiovascular events that we're trying to avoid. So those studies really cemented a movement away to more selective agents. But nonetheless, when you look at the efficacy, these drugs are very similar regardless of which one you're using. And safety profile-wise, there are BTK inhibitor class effects that we'll also talk about. So once you get into second or third line, it doesn't really change much compared to what we do first line, you now just start to sequence the drugs in classes that you kind of didn't use before. And the NCCN actually has a complicated algorithm depending on the choice that you use. How do you kind of snake through the patient's long-term, 10-year journey? It helps you think about that patient, whether there was intolerance or a recurrence off of drug after some time-limited therapy or progression on agents. But nonetheless, we sequence these drugs, and you can see, yes, the studies might use venetoclax rituximab, and it might be 2 years, but that's just based on some of the data that developed these approvals. Once you get beyond those double exposed and even double refractory patients, this is where we're thinking about CAR T cells. This is where we're thinking about reversible BTK inhibitors. We technically have PI3 kinase inhibitors still approved in this setting. And then obviously there are some other older treatments that can get us out of a hot spot but have toxicity issues, and we're typically still reaching for these newer approaches because of toxicity profiles, efficacy, as well as potential for long-term remissions. Here's the pirtobrutinib data. This is from the Bruin study. This was a large phase 1/2 that eventually expanded to get enough patients and enough data out there to get an accelerated approval for pirtobrutinib, which is a non-covalent reversible BTK inhibitor after prior exposure to a BTK as well as a BCL2 inhibitor. And here you can see this was a large study, close to 300 plus, 350 plus patients enrolled with CLL. And what you can see here is that the response rate looks excellent, 80% or so response rate. This is what these patients had 4 to 5 prior lines of therapy. Most of them all had chemotherapy, very high risk patients getting excellent responses. And it was regardless of whether you were double exposed / double refractory or not. Even those double exposed refractory patients actually had similar response rates. So we can actually rescue patients with this drug, and it, again, was regardless of del-17p, BTK mutations, and any other risk feature that you look at. This drug is a very, very active agent, also a very selective agent. Here is the PFS. Keep in mind, 4 to 5 prior lines of therapy. Median was 4 in the entire cohort, but a PFS of 20 months, so almost 2 years, a little over a year and a half. Half of the patients are doing better than that. You can see 30 to 40% of these patients are getting out beyond or close to 3 years. And, an excellent option that you can reach for, that you can take very high-risk patients with these accelerated CLLs, and you can actually start to get control of them and have durable remissions and maintain disease control for a good period of time. Obviously, we still need work. You can see half of the patients are progressing. There are patients who are going to be destined to fail these drugs, particularly our chemotherapy previously treated patients who have really complex karyotype disease. They are destined to fail these agents. We may see less and less of that, and these outcomes will only improve upon each other as we see less and less of those patients being enrolled into these studies. But there is still work to be left, and 20% of patients or so have complex karyotype del-17p at diagnosis without any prior therapies. And so this is a unique patient group that I think will need more than 2 classes of drugs, that will need more than just a BTK and a BCL2 inhibitor, and we need to be thinking about these newer agents as well. Here, if you are BCL2 naive, have never seen venetoclax or a drug like it, you actually can do a little bit better. Presumably, maybe it was some intolerant patients in this group as well, but nonetheless, there were some patients who have gone from BTK straight to a covalent to a reversible on this study, and you can see that their PFS pushes out to 2 years, 23.4 months or something. Right around 23 months. Overall response rate looks good. Those patients who are double exposed, many double refractory, do obviously have higher risk disease. You do see a little shortening of that PFS. Here, that median is around 16 months. So these are the patients that, we need to be thinking about it, because you can see at 2 years, almost everybody is off of that curve. And these true double refractory patients are a unique patient population that we need advanced therapeutics for still. So what are some practical takeaways from all this? Obviously, when you are treating patients with BTK inhibitors, safety is a big concern and a big differentiator on how we are thinking about which drug to use, but also dosing is rather different of these agents. Acalabrutinib is strictly a twice-a-day drug. We know BTK occupancy and response rates and things are better with better coverage over twice-a-day dosing. That was figured out very early on in some of the earlier phase studies. Zanubrutinib, while most data that you see, long-term survival data, is generated in twice-daily dosing, the PK and BTK occupancy still looks very good with once-daily dosing, and early data, safety data, et cetera, from earlier studies with once-daily dosing also supports that. And so there is an option for your patient, and some patients do like once-daily dosing versus twice a day. And so that's something to consider as you're thinking about this. Ibrutinib is a once-a-day drug, and typically now one pill. Zanubrutinib is still 4 capsules. So there is pill loads and things like that that patients will talk to you about. Pirtobrutinib is also a once-daily drug, 2 100 milligram tablets. BTK inhibitor class effects, they are there. You can't get rid of them. You try to mitigate them. You can't ignore them. Just because you're using a more selective drug doesn't mean, hey, I don't have to worry about AFib or checking for it or watching for bleeding. These things are there, and we have to be thinking about them. And the big classes are arthralgias, AFib, arrhythmias, bleeding, hypertension, and GI side effects. These are the super common things, and many of them are nuisance. They're low grade, the joint aches and the brittle nails and some of these things that you see, and the bruising, it's cosmetic, but it can really bother patients. So it is something that we need to think about and even adjust dosing for. And so we've generated now a lot of data too around dose reductions, particularly with ibrutinib, showing good outcomes still, even dose reducing. So, the coverage is very good even at lower doses. So it's a way to keep patients on a very effective drug without potentially affecting a long-term outcome. CLL is like a perfect model for shared decision making, and so that's really what this slide kind of depicts. This is a decision made with a lot of people involved: the patient, their caregivers, your oncologist, your cardio-oncologist, your other colleagues, the nurses. You have a lot of time. The patients typically can have a lot of education before they're and seek education because they're not in extremis typically trying to start a treatment urgently. And so you can start to start laying the groundwork on this decision making very early on, start to assess preferences, and realize that patients are living decades, and what they thought about early on was important to them changes at a relapse 7, 8, 9 years later, as they're now 80 years old instead of 70 and looking for different priorities in their life. So these things need to be reassessed at all times, and it is really a perfect model for shared decision making. So with that, we got through all of that, so we'll go to some of our questions here. Here is kind of to assess what you think about now after seeing some of this data. You have this 72-year-old patient, again, treatment naive, DEL11Q, unmutated IGHV, that same patient that we started therapy initially on. Seeing some of this continuous therapy data, what would you select for this patient specifically? Okay, so it looks like for the most part things didn't shift. There was people still staying with covalent BTKIs, mostly second generation, any covalent, and if anything, maybe a little bit more fixed duration after seeing some that the younger age and things like that possibly coming in. But a little bit of change, for the most part, pretty consistent. All right, so as you can see, there's a lot of no absolute certainty here. There's a lot of options. All right. Here's another assessment of what your thoughts are here. Thinking about sequential use of continuous therapies and non-covalent BTKIs in relapse refractory settings, in which settings would you now consider using a non-covalent BTKI? And so would you only use it in that double exposed disease after progression on the covalent and venetoclax or BCL2? In the covalent BTK resistant disease, meaning venetoclax naive, you jump to it soon, or in BTK intolerant disease, would you go to it first before maybe switching to a different second generation? So people are keeping it in the back pocket for the most part, and if anything, maybe more keeping it in the back pocket than previous for that niche where it's currently, the indication currently is after double exposure, double refractoriness. I think there was some less using it in venetoclax naive patients, and there might be a little bit more of a jump to using it in intolerant instead of cycling through some of these covalent BTK inhibitors based on some of that safety data. All right, very good. And now I'll hand it over to Dr. Lamanna, who will take us through time-limited options in CLL.
Thank you, John. So we're going to go through some of the time-limited approaches, and we'll start with the case. This is a younger patient, so you have Charlotte, who's 62, so younger than the case that John presented earlier, with progressive lymphadenopathy and splenomegaly, marked lymphocytosis with some anemia and thrombocytopenia. She has no deletion 17p. She's unmutated, but no deletion of, as I said, no deletion 17p or TP53 mutation. So I guess for this, again, a similar discussion that we had earlier, and I will punt this to John. We're leaving Bill off the hook today, but he's got a lot to do for the meeting. So given this, what do you think about, again, we could have the same discussion, continuous therapy versus a time-limited approach for Charlotte?
Yeah, I mean, I think my typical approach for these younger patients is a time-limited therapy. Typically, in this day and age where we're still at, is still Ven/Oben. I'm still trying to figure out how do I place perfectly combinations and doublets and even triplets. I think if this patient had a mutated IGHV, it's kind of the no-brainer. That's a Ven-G patient in my mind, low tumor burden and low-risk disease. They do phenomenally well. We're going to see some of that data. But even with an unmutated IGHV, they do very well. And her younger age, keep her fit and keep her off medicines and avoid toxicities and nice remission.
Good, and we're going to talk a little bit about the counseling that we do for the Ven/Oben in a little bit. So now let's say she's same patient, but she's bulkier. So her lymphadenopathy is 10 centimeters, but she's still young, she's still fit. Here, even though we don't yet have the approval, and again, we're obviously going to be talking about oral-oral combinations, this might be a consideration for BTK-Ven regimen given her bulky disease. I think, that might be a unique opportunity, so we'll talk about that, and we'll talk about both first and second generations with BTK-Ven in this setting, and we'll talk about some of the factors that we might consideration in this time-limited combination. So just to kind of sum it a little bit in, so non-bulky, I agree with John, the mutated younger patients perfectly for a time-limited approach, similar to what we used to do with chemoimmunotherapy, give them something time-limited, get them off treatment because they have, good prognostic markers and will likely buy a long period of time off therapy. Of course, you still, if you're using time-limited approaches, need to consider whether they're low, intermediate, moderate, or high risk based on their lymphocyte count and also their tumor bulk, their lymphadenopathy, so you'll still need to categorize them for TLS monitoring. And then if you're really bulky, this might be an ideal approach for, a BTK-Ven combination where you can debulk somebody where you're very worried if their lymph nodes are 10 plus centimeters, you're very worried about TLS, and so front loading with a BTK inhibitor might be ideal in this situation, and we'll talk about that data as we're getting increasing data from the oral combinations. And why a time-limited approach? Well, obviously it's appeal for many patients who don't want to be on a chronic continuous therapy. And also, obviously, the time-limited approaches have the ability to render the disease in, a deeper remission, so to speak, quicker, which gives them a break off of treatment. So the potential to stop treatment when you're in remission, similar to what we did again in the chemoimmunotherapy days. Obviously, also not being on chronic continuous therapy, where you could have some prolonged and nagging toxicities that John alluded to with some of the continuous BTK inhibitors, the GI toxicities, nail pitting, bruising, et cetera, you will have a shortened period where some of those toxicities will be, but then you are off of therapy. Cost effectiveness, of course, being off treatment for a period of time, rather than chronic continuous therapy. And of course, we always think about the development of resistant mutations. We saw that John presented about the BTK resistant mutations that can develop with continuous treatment. If you get a time-limited approach, will that mitigate for some of the resistant mutations that we're seeing from some of these therapies so you could retreat them later on? And hopefully we'll have longer-term data for this. So obviously the time-limited approaches, as John alluded to, we have venetoclax and obinutuzumab as standard of care in frontline treatment, and then you have venetoclax rituximab in subsequent lines of therapy, and this data comes from CLL14, as which we have longer follow-up. So you have ven-obinutuzumab versus obinutuzumab and chlorambucil, and now the median PFS, 76 months versus 36 months with obinutuzumab and chlorambucil, with a 6-year overall survival of 79% versus 70%. And median time to next treatment has not yet been reached for ven-obi compared to obinutuzumab and chlorambucil. And although I'll bring up we always talk a little bit about, as John alluded to, the issue in patients with high-risk disease, the P53 and the deletion 17p patients, still good therapy. The PFS, again, maybe perhaps, again, indirect comparison to chronic continuous treatment, may be a little shorter than the chronic continuous therapy, but still a very good treatment option in comparison to chemoimmunotherapy that we did years ago. And then, now remember, that's 12 months of therapy in the frontline setting, and then switch to the Murano data, which was 24 months with the combination in the relapse setting. Now, albeit this was a different patient population, the majority of these patients were not BTK exposed. They had prior chemoimmunotherapy, hence why you see the median PFS of the bendamustine rituximab arm looking so short at 17 months versus 55 months for venetoclax rituximab, the 7-year overall survival 70% versus 51%, and the median time to next treatment 63 months in the ven-R arm. So very good treatment for these time-limited approaches. Now, obviously, the shift now focusing on the oral-oral combinations, and so why would we want to consider doing that? Well, we know these drugs work very differently in the different compartments. The BTK inhibitors do a wonderful job at eradicating the tumor bulk. The lymph nodes decrease in a matter of weeks. I mean, when we had patients initially on the ibrutinib studies who got chemoimmunotherapy, and it would take them several cycles for their lymph nodes to shrink, and then in a matter of just a couple of weeks, all of a sudden they vanished. I mean, you never saw anything like that. It was just remarkable when these drugs first became available. And then, of course, the venetoclax does a phenomenal job at eradicating the disease in the bone marrow. And so these really do have complementary mechanisms of actions to put people in deep remissions from just a time-limited approach. And hence, we're going to show this data from, most of this stems from the ibrutinib venetoclax data, but as John was alluded to, we're obviously seeing more and more mature data with the second generations as well. And we have an approval in Europe with ibrutinib and venetoclax from the GLOW data. So just to give a sense from some of the many different trials that have been run with ibrutinib and venetoclax with time-limited therapy here, you have data from the CAPTIVATE study, which was 12 cycles of the combination with a 3-month lead-in from ibrutinib, and there was both a fixed duration cohort where everybody received treatment and then completed therapy and was off, and then there was also a minimal residual disease cohort where patients completed the therapy, and then based on their MRD status, they either, if they were negative, they either continued ibrutinib or were randomized to placebo, or if they were MRD positive, they were randomized to either ibrutinib or continuation of ibrutinib and venetoclax. But you can see here that the patients did really well. The 5-year PFS was 67%. For this combination, and again, this was about 15 months of therapy, just keep that in mind. We have the longest, we also have more mature data from the MD Anderson, and this also initially started as 12 cycles of therapy, but with follow-up of MRD, they extended that treatment even longer, and so it continued on, and for patients they can go to 24 cycles of therapy, and with longer follow-up of this data of 120 patients, the 5-year PFS is 90%. And then we have data from the UK, the FLAIR study, where, again, a little bit more MRD-guided therapy here, where patients could, as soon as they were detected to were undetectable MRD, then they would double the time period from that point on for continuing the combination. So you could be a minimum of 2 years on therapy to a maximum of 6 years of treatment. And here, a little bit shorter follow-up, but the 3-year PFS here at 97%. And so this highlights, not only the efficacy of the oral combinations in terms of how well they're doing in regards to PFS, but it also highlights the fact that, what we've chosen for how long these time-limited approaches are a little bit different depending upon the studies. And, do we have an ideal duration of therapy for time-limited approaches? Is not quite defined. Most of them have centered around 12 months, but there are some studies that are going beyond 12 months depending upon MRD status. Let's talk about some of the data from the second generation agents. So we have data for both zanubrutinib and acalabrutinib. This is data from the Sequoia RMD. Just to remind you, these are patients with high-risk disease for 17p or p53 mutations. and the overall response was 100% here, with a CR/CRI of 48%. You can see how well this data looks. There's also a triplet with zanubrutinib, venetoclax, and obinutuzumab, the BOVEN study, with 89% of patients at undetectable MRD at 10 months. So we'll look for longer follow-up, both from the doublet and the triplet with zanubrutinib. And then, of course, we have data with acalabrutinib. This came from the Dana-Farber, looking at the triplet combination of acala, ven, and obinutuzumab in the relapsed refractory patient population. Also a very high-risk patient population. The majority of patients, 60%, were TP53 or deletion 17p. Many had a complex karyotype, and the majority were unmutated. Very active regimen. You can see here that the bone marrow undetectable MRD rate was 83% in TP53 patients after 15 months of treatment, and the 3-year PFS was 93%. And you can see here that the degree of undetectable MRD has increased over time, and so we look forward to more long-term data with the triplet in these high-risk patients. And of course, as many of you are aware, we have the study Amplify, where we had an early interim analysis, and hopefully this data will get presented soon in more detail, that it has met its primary endpoint. So this is a randomized trial looking at AV for a year versus AVO for a year versus chemoimmunotherapy with either FCR or bendamustine rituximab. And the primary endpoint has been met, that the AV plus or minus the obinutuzumab arm improved PFS compared to chemoimmunotherapy. And so hopefully this will get, the details of the study will get presented soon, and this might lead to the first oral approval in the United States. As we know from the GLOW data, ibrutinib and ven is approved in Europe, but that combination has not yet been approved here in the US, and likely it'll be one of the second generations that will get approved. So just to center on some other time-limited approaches, that we need to go to, and John already alluded this, in our multiply relapsed refractory patient populations, even though for some of these individuals, they might be only seeing a BTK inhibitor during their lifetime, or even ven-obi during their lifetime. If they're older and are doing quite well, that might be one treatment might be enough for them if they're an older patient population. But our younger patients more often are going to get more than one line of therapy, and we'll see probably both BTK and obviously ven-based treatment combinations. And then, of course, there are many of our unfortunate folks that have had both of these agents and are becoming relapsed and refractory to both a BTK and ven-based therapies. So CAR-T was recently approved, for those of you who don't know, in March of this year. This is the data from Lysocell with the Transcend data, and so patients had to have failed or been ineligible for a BTK inhibitor if they were high-risk disease, and that was defined as patients who had either deletion 17p, p53, or complex karyotype, or were unmutated. You had to have at least failed 2 prior lines of therapy. If you were standard risk, you had to have at least 3 prior lines. So these were heavily pretreated patients. They were lymphodepleted and then went on to receive Lysocell and of 1 or 2 dose levels, and settled upon the dose level 2. And this is just some data in patients who had BTK progression and venetoclax failure, small subset of patients, but 20% of them, almost 20%, achieved a CR. And that, unfortunately, it's not more, but in the patients where CR was achieved, those patients, the responses seem to be durable. And that's important in this heavily pretreated patient who is, as I said, got BTK and ven failures. The other patients, of course, the responses are less durable, and as John alluded to, who is then needing to think about alternative therapies for these double refractory patients, because they probably will need to be bridged to alternative therapy, particularly depending upon their age and their comorbidities. But this is now nonetheless approved for relapsed refractory patients who have received at least 2 prior lines of therapy, including a BTK and BCL2, and this approval just happened in March. Now, what about the non-covalent BTK inhibitors? John spent a lot of time talking about pirtobrutinib in this setting, and so, obviously that's now approved, after BTK and ven-based combination as monotherapy, but we're starting to see combination trials for time-limited approaches with pirtobrutinib. Here's a combination trial looking at pirtobrutinib and venetoclax with or without rituximab. Overall responses are very high for either arm, and high rates of undetectable MRD. We'll see whether or not the addition of rituximab is needed for the PV combination, and so far there's been no dose-limiting toxicities. And the most common AEs we're seeing are the neutropenia, the GI, fatigue, and nausea, similar to what you would see from these drugs in and of itself. And so that's looking very encouraging for more follow-up. And then the Pirto combination with venetoclax obinutuzumab, our colleagues here at MD Anderson, led by Nit and Jane, also presented this data at EHA, looking at PVO in frontline setting for patients with CLL, where they start the Pirto OB in cycle 1, it continues. Actually, the venetoclax doesn't get added in until cycle 7, and there's both CT imaging, bone marrow testing, NGS testing for MRD that is done. If they still have disease at the end of the 12 months, 13 cycles of therapy, they can go on to continue PV for another 12 months. But very high responses so far, very high levels of undetectable MRD in the bone marrow and peripheral blood. So they're expanding the cohort of their initial set of patients to include more patients, and so we look for more data for this as well in the near future. So what are some practical and safety considerations for time-limited approaches? So as I alluded to earlier with venetoclax and the antibody combinations, you're going to assess the patient for tumor lysis risk. For the Ven-OB combination, most of the time the obinutuzumab can be dosed first, and then you can initiate venetoclax a little later into the obinutuzumab dosing. For the rituximab, the Ven-R, you can start with Ritux and then do the 5-week ramp up. Again, you have to assess what your tumor risk is at baseline and then work that accordingly and monitor tumor lysis as per labeling. What about the oral combinations with venetoclax? For most of these studies, there's a lead-in with the BTK inhibitor with standard dosing of whatever BTK inhibitor is being used. For the Captivate or the ibrutinib venetoclax trials, most of that was a 3-month lead-in. There were some studies that did a 2-month lead-in with ibrutinib and then followed by 12 cycles of ibrutinib and venetoclax. With the Sequoia RMD and Acala arms, again, similarly, they had a lead-in with their BTK inhibitors before adding the venetoclax into the combination regimen. And for the majority of these, obviously that makes it much easier in the sense because it is oral. You can debulk the patients, their lymph nodes markedly shrink, and the majority of these patients, if they had high-risk disease, are then downgraded to low or moderate-risk disease and then don't have any trouble then when they do the venetoclax ramp-up for outpatient monitoring of their labs. Now, what about safety? Now, obviously, we know about the different aspects of, we talked about the BTK inhibitors and some of the safety issues with BTK inhibitors. The venetoclax, we talked about the tumor lysis. There's also more myelosuppression, given the fact that it does such a great job at mopping out the bone marrow, and so we do tend to see a little bit more neutropenia with venetoclax. So you have to factor that in, albeit with the time-limited approaches, it'll be time-limited, but still there's mounting toxicities when you combine these two agents together. From the GLOW data, they saw more infectious complications from the combination, obviously because of the BTK inhibitor, you're going to have some of the cardiac issues that come about. Hence, I think, why they're looking more to the second generations for approval here in the U.S. due to some of the cardiac issues, even though it's a time-limited approach. And with the Captivate, they saw some similar issues, a little bit more neutropenia, infectious complications. There was a sudden death in one patient early on. We have also data with the doublets with zanubrutinib and venetoclax, and you can see the infectious complications, although mostly grade 1, grade 2, they're still very frequent. So you gotta, counsel your patients about calling about infectious complications. Again, more neutropenia associated with the combination. Again, most of the adverse events are grade 1, grade 2, but you see more grade 3 and above with infections, neutropenia, and so on and so forth. And here's some of the data with AVO. Similarly, more now when you add the obinutuzumab into the oral combination, you do get more myelosuppression, you do get more neutropenia and cytopenias because of the obinutuzumab added to the AV combination, so more cytopenias with the triplets. And you again have to think about that with regards to infectious complications. Apparently there was no febrile neutropenia or opportunistic infections on the study, although they did allow for prophylaxis. But you definitely do have to counsel the patients about infectious complications and monitor for cytopenias. On this combination, there was dose reduction in about 20% of the patients with the triplet, so just keep that in mind. So just to go back to some questions, if you please. We have the 62-year-old, she's treatment naive, unmutated, no deletion 17p, lymphadenopathy 10 centimeters and splenomegaly. Assuming all options are available, how would you now treat this patient? Time-limited Ven-OB, time-limited BTK and Ven, ibrutinib-based, time-limited BTK and Ven, second-generation BTK, continuous BTK therapy, I'm not sure. Please answer. Good. So it sounds very similar to before, although it does sound like post there's a little bit more time-limited BTK and ven with a second generation for this patient who's young with bulky disease. And then the second one, you are considering a time-limited BTK and ven regimen for a patient with bulky disease. What dosing strategy would you use to optimize efficacy and ensure safety? I'm unsure of dosing strategies. Lower the dose BTKI with standard dose ven, standard BTKI dosing with lead-in prior to venetoclax, standard BTKI dosing with venetoclax, no lead-in. Please answer. Hopefully you get this all right. Great. So the majority, so standard BTKI dosing with lead-in prior to venetoclax would be the way to go. Excellent. Okay, so now I'm going to turn it back to Bill.
Great. Thank you, Nicole, and thank you, John, for your excellent presentations and a lot of data and a lot of information that you all went through. I'd like to use the last 10 minutes to go over questions. There have been some great questions submitted, so I'm not going to spend a lot of time on these next few slides. There's a summary slide which maybe I'll spend time on. There are new agents in development, one of which is the degraders. BTK is an exceptional opportunity to develop degraders, in my opinion, and that is because it's such an important molecule in the CLL cells, and this is a different mechanism of targeting it through accelerating its degradation and eliminating the protein through degradation, as opposed to using a small molecule inhibitor to inhibit the kinase. And so we are seeing data that's being emerging with regard to the degraders, and they are looking very promising. And I think it also opens the potential opportunity to target other proteins in CLL and other cancers through this mechanism of action. We know there are other BCL2 inhibitors in development. Sonrotoclax is shown on this slide, and we'll see more data about these other newer BCL2 small molecule inhibitors. And then the bispecifics are emerging as an important modality. So there are a lot of opportunities, and we're seeing more and more exciting data generated. This is my summary slide, and I think probably the two operative words for today are individualize and optimize. And we heard a lot of data and insights on optimizing and also individualizing treatment for our patients. Thinking about characteristics of the patient and selecting the treatment that is most appropriate for those patients. And I've listed some of the thoughts and things that we think about in that regard on the left hand of the slide. And then optimizing, and we're always looking to do better for our patients and to improve outcomes for our patients. I believe that we're close to having a curative therapy for patients. It's hard to conceptualize optimizing continuous maintenance therapy other than to improve the tolerability and reduce the toxicities. I'm very excited about fixed duration or time-limited therapy and that opportunity in terms of developing curative treatment. That might come through developing consolidating strategies where you have patients who are on a BTK inhibitor, you've debulked them, and you're coming back in subsequently or later on during the treatment to consolidate those patients, eliminate the leukemic clone, and get them off treatment. And then we have heard today, and we'll be hearing a lot about optimized time-limited combinations. BTK plus BCL2 plus CD20 antibody, et cetera. So it's a very exciting time in CLL for me, and it's been an exceptionally gratifying time over the last 10 years to see all of the progress in our therapeutics. So with that, we're going to go to questions. If you have any questions, you can submit them. At this point, we have a number of good and interesting questions. Maybe we'll give Nicole a little bit of a break, and we'll start with John. There's a couple questions here with regard to On one of your slides, you mentioned sequencing BTK and looking for BTK mutations. So there's a few questions about that component and thinking about how sequencing a BTK and how that might be clinically useful in management of patients. So maybe can you comment on that aspect?
Yeah, sequencing the gene, BTK.
Sequencing BTK, looking for mutations in BTK.
Yeah, I think obviously when you're progressing, we have the ability to look for mutations and to see what is being acquired. We know that patients are acquiring these mutations, and right now in this time period, we don't really have an approach, particularly if someone has a CIS41 or even a different type of mutation, a kinase dead or a gatekeeper. We don't have an approach to use in a specific setting with that information. With that said, it does set some expectations for potential outcomes. It is prognostic in many of these settings. We know reversible BTK inhibitors like pirtobrutinib and even nimtabrutinib has shown some data there that the presence of a BTK mutation does not necessarily impact the longer-term PFS and or even response rates. And so that, I think, is important. It's important to know if it's there, but it's not really going to change how you think about the patient or the approach or the sequence. I do think in the future, though, as degraders come available, as potential bispecifics and maybe less toxic immunotherapeutic approaches become potentially available, we may think differently about a specific type of BTK mutation or acquisition of an event. When we have different drugs like degraders that can address specific type of resistant mechanisms. So right now, I look for it. It is very important to retest for these types of abnormalities. It will impact an outcome, whatever that second-line therapy typically might be, and it's information prognostic, but I do think it will continue to evolve, and we will potentially impact our therapeutic choice.
Great. Nicole, in terms of time-limited therapy and giving a fixed duration of treatment or treating till MRD undetectable, and thinking about remission and duration of remission and resistance and switching therapies from fixed duration to another strategy, what are your thoughts around what's a reasonable duration of time off treatment, and when do you think about resistance, and how do you consider that in management of patients with?
Yeah, we didn't really talk about retreatment given the time allotted, and so obviously, right now we talk about this 2-year landmark. So if you've gotten some sort of time-limited approach with Ven/Obi or Ven/Rtux, then come off of therapy. We'd like to see at least a response duration that's going to last a minimum of at least 2 years. Now, obviously, there's a trial trying to address, really prospectively what that means. Is it 2 years? Is it 12 months? 24 months? If somebody, in my mind, comes off a time-limited combination and then relapses within a short period of time, actually the patient that where they relapsed 10 months after finishing Ven/Rtux, to me, that would be not somebody I would re-challenge on Ven/Rtux. That's a really short duration off of therapy. So you really want to see a couple of years out that somebody's had a response to that therapy. Then you could reconsider re-challenging that therapy potentially. The Captivate data is looking obviously at some of this as well. Can patients be retreated if they've come off therapy? And we're seeing successes with that. We've seen successes with the Murano study as well. So the longer somebody's had a response duration to a time-limited approach, you can certainly consider a re-challenge, or obviously, depending upon what agents they had before, you can go to the alternative agents. So if they got Ven/Obi, can you go to a BTK inhibitor? Of course you could. So, but certainly you could also consider re-challenging that patient with similar agents if they had a nice response duration. The defined time has yet to be completely clarified, but we want the longer the response, the better.
John, here's an interesting question. Thoughts on using non-covalent BTK inhibitors as a bridge to cellular therapy?
Yeah, I think when I showed you the data, those double refractory patients, 25% of them were progression-free at year 2. So it is something that in these really high-risk patients, while it's great to have available, and it can get people out of a tight spot and some hot water, you still are going to expect progression in these patients. And so I think in those types of patients that we start a drug like pirtobrutinib or reversible BTK inhibitors, you almost have to be thinking about it as a bridge towards something. Now, if they are younger and they're 68 or 70 and pretty fit, that is where I'm starting the drug and starting to have the conversation about, hey, consolidation, because the data that we showed, while it's 20% getting these CRs and it's IWCLL criteria and it's very strict and that's a really deep, great response, they can almost have potential cure. And so that is something where, yes, we need to be thinking about that transition. I think once you're reaching for a reversible after double exposure or double refractoriness, that is where CAR T's role really is. And when, I don't think we know the right answer of when to actually move to CAR T. Once you get into a response, do you try to eke it out as long as possible? But, it's such a collaborative, long process to get CAR T administered to a patient that you have to be thinking about it months in advance. And so I think that's where having the conversation, meeting the team, and being ready to go when you think it's the right time.
Great. So, Nicole, maybe can you give some insights on MRD testing, test to use, when is MRD important, how do we use it? Do we do MRD-directed therapy, or do we stick with fixed duration therapy?
Yeah. I mean, obviously, the data really shows that MRD is a prognostic tool, for a surrogate in a way for PFS. And so if you have undetectable MRD, the longer that response will be, the longer the PFS and time to next treatment. In fixed durations, obviously, we're trying to figure this out better. There's obviously moving targets with how you test for MRD, the depth and NGS testing and so on and so forth. And obviously, the more sophisticated the testing goes, the deeper the level of remissions, the more important that will be. We need to standardize that, of course. And it will become important, I think, for some of these time-limited combinations, because that's, as I showed you earlier, as we're trying to figure out, which are the patients where you can fine-tune, as Dr. Wierda alluded to, individualize the therapy, where you might benefit from continuation if you're MRD positive versus you're not. And so I think that's, in practicality right now, we're telling most oncologists, if you're giving Ven-Ob, you're giving 12 months and you're done. But we're trying to really individualize these treatments and figure out who are the best candidates to continue therapy, because albeit there are some patients that will be MRD positive regardless of how long you continue those treatment, and obviously you want to give them a break off treatment. So yes, it's in a very simplified fashion, it is we need more work to be done with regards to MRD testing, and hopefully we can clarify the timing and duration of these, when MRD testing should be done, depending upon the regimen, and who would benefit from changing the algorithm, meaning staying on treatment perhaps a little longer than what you've seen defined in some of these current trials.
Great. Maybe one last quick question for John. We didn't talk a lot about continuous BCL2 therapy, continuous venetoclax-based therapy. Maybe can you give a brief comment on that treatment modality?
Yeah, it's a approved option. It's a great option. It was initial approvals were basically based as monotherapy continuous treatments. And I still do that in my practice. There are patients that who are pretty heavily pretreated that I've got them in an MRD negative state or a deep remission and doing well, that I'm still a little hesitant to stop them because I'm not so sure of what I can rescue them with necessarily if they start to progress, or if the drug will work again when I go back to it. And so it's that old axiom, if it's not broke, don't fix it. Now, we don't have a lot of data to necessarily that's right or wrong. We know the PFS is about 2 years in BTK progressors who go on to monotherapy, continuous therapy, venetoclax, which looks similar to even like pirtobrutinib and things along these lines. And so I think it calls into question, how do we use it? Does it matter? Because it is a very different mechanism of action than BTK inhibitors that do shut down proliferation. This is not necessarily doing that, and is having drug on board necessarily doing much, but potentially even breeding some resistant escape mechanism possibly. So I think there's some questions there, but it is something I do. It is a very well tolerated drug, and people who are in nice deep remissions, I sometimes do keep it on in these heavily pretreated patients.
Great. So in the interest of time, we'll stop here. I'll thank Nicole and John for your excellent presentations and excellent discussion. Thanks to PeerView for this program. Thanks to the audience for participating. Again, you can go to the website to download the content. Please fill out the survey and have a great rest of your SOHO meeting. Thank you.